right. This is the third and final video in the series, The Details Matter, Perfusion, Pathophysiology of the respiratory system and the cardiovascular system. So in our first two videos, we covered in video 1, the respiratory system. In video 2, we covered the heart. A little too much in one video to get the whole circulatory system, so breaking it up nicely. We're going to end this with our talk about the blood vessels and the blood itself, and then how it all kind of comes together. One thing I want to do, though, before we get into the blood vessels, is talk a little bit about some of those key terms that deal with both the heart and the blood vessels. And those are those terms that we talked about in the chapter on pathophysiology. You're going to hear them over and over again when we get to the cardiovascular chapter. But these are these terms that we have over here to the left. First one's preload. You guys remember what preload was? We talked about how the blood returns to the heart via the veins, and how the superior and the inferior vena cava are the largest of the veins, which bring blood back to the right side of the heart that's deoxygenated. We also know the blood comes back to the heart from the lungs to the left side. Well, the volume of fluid that comes back in on both these sides is known as the preload. And so you have a right-sided preload and a left-sided preload. The right preload is a little bit more in terms of how preload affects the heart. If you were to drop the amount of blood coming back to the heart from the body, it would have some bigger consequences in terms of the amount of blood that's going to be able to be pumped through the heart and then out of the heart. And so when we talk preload, it's a big deal in terms of all of the other things happening correctly. You got to have the right volume coming back. Preload is that. Stroke volume, that's the amount of blood that's being pushed out of the heart with every contraction. So our stroke volume is being pushed out from the right and stroke volume pushed out from the left. When we talk about what's really important with perfusion, both are, but primarily that left-sided stroke volume, getting that good blood out to the rest of the body. Cardiac output, that was another term we talked about. Cardiac output is a formula that gives you a number that tells you a lot about how the heart is actually doing in terms of moving fluid. The cardiac output is determined by taking the heart rate and timesing that by the stroke volume. Now, this obviously is a number just like those other two that we cannot really measure in the field. Now, we can see decreased cardiac output in the form of the signs and symptoms we see with shock. So there is some seeing of what cardiac output does, but we do not have the ability to technically measure it. Afterload. So this is another term that deals with blood leaving the heart, but this is more talking about the pressure that needs to be kind of put behind the fluid to move it forward. And so the afterload is the amount of pressure needed to push blood forward out of the left ventricle into the aorta and keep the fluid moving forward. That afterload pressure has got to be higher than the resting pressure inside of the aorta or in the artery system, period. So afterload is a pressure thing. Blood pressure is a culmination of all of this. Blood pressure is cardiac output and systemic vascular resistance, or the resistance to the push of blood forward that the blood vessels give us. You have to have both components working well in order to maintain a blood pressure. The cardiac output side has got to be pushing out enough blood at the right pressure in order to get that good top number, the systolic pressure, which is the pressure in the system during contraction of the ventricles. The bottom number of blood pressure, the diastolic, is the pressure that's in the system when the ventricles are relaxed, or the resting pressure inside of the aorta and the other arteries. Remember, we have to beat that resting pressure in order to move blood forward. So that's why your systolic pressure will always be higher than your diastolic. All right, now let's talk about some vessels. So we've got a nice picture here. This picture here is of the great vessels coming off of the heart, leading to the body, the aorta, and also the inferior and superior vena cava, which are bringing blood back to the heart. Also in this picture, we have a nice kind of depiction of the pulmonary arteries and the pulmonary veins as they kind of weave and make their way through the bronchioles here. We know that the circulation inside of the lungs is extremely important in order to bring that deoxygenated blood from the heart's right side to the lungs to drop off carbon dioxide and to pick up oxygen to take to the cells. Let's take a little bit of a moment here to go over what that respiration looks like.
For a little Pathophysiology quick hit. Respiration. We've got external respiration that takes place at the alveoli capillary bed connection. This is where the red blood cells are picking up oxygen from the lungs via diffusion, dropping off carbon dioxide to the lungs. The heart then pumps all that blood to all of the cells of the body, where internal respiration takes place. The oxygen's being offloaded so the cells can use it, and the carbon dioxide is being picked up by the cells in the blood, taking it back to the heart, to the lungs, where the process just repeats over and over again.
Okay, back to what we got going on here. Let's take another peek here at another view. Okay, so when we talk about the vessels, we got to think of it as a network. That network is designed to supply blood throughout the body. And remember, anything we see in a video or a picture that is in red is going to be an artery, and everything we see in a picture or a video that is in blue is going to be a vein. Now, one of the things you'll notice is that this network, the container as we call it, kind of runs side by side each other. Where you see a large artery, you tend to see a large vein. This is designed to be that way. Now, the veins are more superficial than the arteries are. So they do come closer to the surface of the skin, which is why they're easy to see on our bodies. If you look at your arms right now and your hands and other areas, you can see the veins. Another reason is that the color of the blood is a little bit different. We really do not see arteries. We feel arteries because of the pressure in them. Remember, the arterial side is that higher pressure side. That is why we have pulses produced by the arteries. The venous side is a lower pressure side. It moves blood forward with the contraction and relaxation of your muscles. Also, your breathing has a big part. The pressures, that negative pressure that breathing that creates, helps to kind of suck blood back towards the core through the venous system. The veins also have a network of valves throughout them. And any of you that start working with paramedics when you get out of here, one of the things you'll hear them say a lot is when they're starting an IV, oh, crap, I'm up against a valve. That is very common, and one of the things that you only really find in the venous side are those valves. And so if you take a look at the larger arteries and the larger veins, most of them are through the core of the body. This vena cava, this aorta run the length of the spinal cord, and they are very large vessels. Any issue with them in terms of rupture or injury can be catastrophic to our patients. And if you take a quick look through this, you'll see that those vessels stay rather large even as they go through our pelvis and work their way down into our legs. So the aorta, for instance, has a abdominal section to it, and then it crosses into two sections of the iliac here, and then down through the femoral area. And these are pulse points too. You can check for a femoral pulse on your patients by pressing in on their inner thigh here and feel a pretty good one. And then as it comes down towards the feet, it starts to get more narrow. The capillary or the arteries tend to get a little smaller and smaller and smaller, and it just works its way all the way throughout the body. The connection between these two systems, the arteries and the veins, takes place in the capillary network. These arteries and veins that you see perfuse all parts of the body. There's a network throughout. And look how many we have actually through our abdominal area. It's because we have so many different organs in there that there are just tons of cells that need oxygen. There are tons of cells throughout that whole area that need to be perfused constantly. So the network of veins and arteries and capillaries is very large through our abdominal area. But if you think about why that becomes problematic with abdominal injuries, it really starts to make sense. There's a lot of area to get a lot of significant bleeding in this abdominal area if these arteries and veins are affected by injury. Some of the more common arteries are the ones that we know are the arteries that run up through the neck, the carotid arteries. That's a pulse point you learned in CPR. Remember, any patient that you approach that's unconscious or that looks to be unconscious, this is where you want to get the pulse check on them. You don't want to go to the wrist for a pulse check on anyone that's unconscious, unresponsive, or seems like they might be in cardiac arrest. Now, if your patient is awake and talking to you, we don't go to this pulse point up here. We're going to go to, if they're an adult, we're going to go to the radial artery, which runs down here along the radial bone. And if it's a child, we're going to do the brachial artery, which runs here right underneath the bicep in that area there. This is the subclavian artery here that runs across the shoulder blades. They put in central IV access there sometimes. Most of the IVs that you're going to see started on the ambulance are going to be started in the veins that are in the hands, the arms, and occasionally in the foot if it's just a rare circumstance. We're also taught as paramedics to put scalp vein IVs into babies. But if we can't get an IV in any of these areas, well, we're just going to switch it up and we're going to actually put an interosseous line in where we actually drill through the bone to access the vasculature. One of the things about bones, and this is very important to understand, is that bones are living. They're living tissue. Bones are very vascular on the inside. Bones are where a lot of the blood cells are actually formed. So we can access the vascular system through the bones. The most common places you'll see that are here on the front of the tibia and also on kind of the corner of the shoulder is also another spot that you'll see medics put in an interosseous line. This one is actually more beneficial because it gets it into the circulation that's a lot closer to the heart. All right, let's talk some blood pressure. So how do we get to blood pressure? Two numbers, systolic and diastolic. Cardiac output times systemic vascular resistance is the calculation used to determine the blood pressure. The top number, the systolic number, is the number that's the pressure inside of the system when the ventricles contract. The bottom number is that pressure when the ventricles are relaxed. The diameter of the blood vessel plays a big role in this, and this is that systemic vascular resistance part. The more constricted the vessel, the higher the pressure. As you watch this vessel dilate, you'll notice that the pressure comes down. Cardiac output, systemic vascular resistance together create this pressure. The goal is to kind of find a happy median. You don't want to be too high, you don't want to be too low. When it comes to shock, we're worried about the patient going too low because it drops in pressure, affecting perfusion. So how does the nervous system play a role? Well, the nervous system makes subtle changes within the cardiovascular system in order to try to control this number or compensate when things go wrong. Okay, now what connects these two systems, the arteries and the veins? Well, it's our capillary network. Our capillary network is the connection between the two systems. And here's where you're going to find all of the cellular respiration and all of the internal respiration that's the cells are doing. The cells are all doing their cellular respiration on their own, but this is where the internal respiration happens between the blood vessels that are bringing the oxygen. They're bringing it to the cells that are all within this matrix here, and they're picking up the carbon dioxide, and that blood is then moving into the venous side. Now, this is reproduced all over, everywhere. That system of capillaries is everywhere throughout this system here. So it's not like it's just one thing that you see there. It's everywhere. Now, when you look at the two different vessels, you start to see how different they really are. If you look at the cross section of an artery, this area right here is all smooth muscle. That is why these arteries can constrict and dilate as hard or as open as they do. It's because of all of this smooth muscle that's needed to continuously constrict and dilate and pulsate as that pulse comes through. There's other layers too. The inside here is that layer where we tend to get some issues with things that are kind of sticking to it, or, this is where fat can accumulate. Take a look over here at a vein. You'll notice that the muscular layer of smooth muscle is a lot smaller. It's a lot less in diameter. So, and it goes to show this is the venous side is not under pressure like the arterial side is. But take a look at this right here. This flap is a valve. And that's what we were talking about, how the venous side has check valves that only allow blood to flow in one direction. And it's because it's not under as much pressure. You don't want to get kind of a regurgitation of blood there. On the venous side specifically, like we said, the venous side runs pretty much with and along the arterial side. It is less pressure. The most popular, I shouldn't say popular, but the most common veins that are going to be talked about in EMS circles are, we'll talk quickly about some access points. So remember, veins are where the IVs are going to be started. The jugular veins, there's an internal and an external jugular vein, and it is a common place for paramedics to start an IV in somebody that's in cardiac arrest or unresponsive. Obviously, putting an IV in someone's neck that's awake and talking is probably not a good idea. Now, as you go down into the arms, trying to pull this whole system up there, you start seeing some of the more common veins that IVs are going to be started. And some of you have probably had IVs put into you in a lot of these veins. This vein here is very common to kind of go what we call the anacubital vein. I'm a big fan of trying to get something in the forearm because this becomes problematic with an IV because of the bend there, and it's not comfortable for the patient. And every time you bend your elbow there, you can kind of shut off the blood or the flow of the fluid through. In terms of the hand, there's quite a few veins you can use there. Any type of larger IV is going to be needed to give up higher. And you'll know one thing about putting in an IV, even though you guys won't be doing it, you have to always go further towards the body if you miss an IV. You can't try to get an IV here and miss and then try down here. Every time you miss, you have to go further this way towards the body. That's just the way that it goes. You've got your femorals here, kind of running down, just like you had your femoral arteries, the femoral veins. This area here is very problematic when you talk about injuries. Any fracture of the pelvis can be very detrimental in terms of the amount of blood loss. You can bleed out from veins or arteries into your pelvic cavity. You can bleed out. You can bleed out into your abdominal cavity, and you can also bleed out into the cavities that your femurs or this large bone sits in. So any injury to any vein or artery in these areas can be life-threatening at a cost in terms of the amount of blood that you can lose. We call that hypovolemia. So that pretty much covers everything with the vascular there. As terms of the blood itself, um, I'm gonna let this speak for itself. I got a little video for you guys to watch on that, and we'll let that run its course. And that's it for this series. We're at about the 20-minute mark. Remember, guys, if you guys have any comments, questions, concerns, please don't hesitate. We're there for you. Whatever you need. We need to get you guys as squared away as possible. We're going to be moving into some exciting material coming up because we're going to learn how to really find problems and then how to fix them. But it all starts with understanding what's happening in the body. So, and once again, I got a little video for you here. And then after that, I'll see you guys in class.